Most of us assume that more testing equals more safety. But for people over 70, some routine checkups can set off a chain of events that causes more harm than good. Today, 5 dangerous health checkups over 70 you need to know about. We'll walk through 5 common exams that are well-intentioned but often risky in older adults, why that happens, and what to ask before you say yes. We'll be direct but careful. These tests aren't bad in every case. The concern is that after 70, the balance between benefit and harm shifts, and what once helped younger patients may trigger complications, anxiety, or invasive treatments with little upside. Recent analyses in journals such as JAMA Internal Medicine, JAMA Cardiology, Neurology Today, and Osteoporosis International highlight how over-testing and incidental findings can cascade into unnecessary procedures. Keep that in mind as we go through each item. If this matters to you, comment below where you're watching from and any test-related experiences you've had. We'll read replies. Now, let's count down from 5. 5. Bone density scans, DECA, meant to prevent fractures, sometimes causing more problems than they prevent. A DEXA scan measures bone density and helps determine who might benefit from treatments to prevent fractures. For many older adults, that seems like a straightforward good. Find brittle bones early, treat them, reduce the chance of a hip fracture. But the reality is more nuanced after age 70. As we age, bone density naturally falls, and DEXA scores often show mild or moderate loss that may not translate into a high short-term risk of fracture. Studies in Osteoporosis International and reviews in geriatric literature point out that treating everyone with low bone density can offer small absolute fracture reductions and expose patients to medication side effects. Bisphosphonates, a common drug class for osteoporosis, are associated with rare but serious problems such as jaw osteonecrosis and atypical femur fractures, and some people develop prolonged reflux or intolerance. In other words, medication is not a zero-cost solution. Rose's story shows how this can play out. At 76, she had a routine DEXA that showed decreased bone density. Her doctor discussed options, and she began a bisphosphonate. Within months, she developed severe jaw pain and swallowing discomfort that led to multiple specialist visits, dental procedures, and anxiety about eating. After a thorough review with her primary care physician and dentist, Rose paused the medication and focused instead on a structured plan of weight-bearing exercise, balance training, vitamin D evaluation with attention to safety, and dietary adjustments to support bone health. Over time, her symptoms improved and she avoided further medication-related complications. So, what should you do instead? Start with a clear assessment of fracture risk that considers age, prior fractures, fall risk, overall health, and life expectancy. Ask your clinician what absolute risk reduction a treatment is likely to provide for someone your age. Consider non-drug measures first when the expected benefit from medication is small. Strength and balance training, home safety to prevent falls, nutrition that supports bone health, and sensible vitamin D correction when deficiency is confirmed. If medication is on the table, discuss the possible harms and a plan for monitoring. Before agreeing to a DEXA, ask, what happens next? If the scan shows mild loss, what do you and your clinician plan to do? And what are the risks of those actions? 4. Brain MRI for mild memory complaints. Imaging that often alarms without changing care. When memory feels a little off, it's natural to turn to an MRI for reassurance. Magnetic resonance imaging is powerful at showing structural issues, and for certain concerns, it's essential. However, in older adults, MRIs commonly reveal abnormalities that are actually typical age-related changes. Small vessel disease, white matter changes, tiny nonspecific lesions. These findings often don't point to a treatable condition, but they can trigger fear, further testing, and referrals that complicate life more than they help. Neurology Today and other professional commentaries have emphasized how MRIs in mild, non-progressive memory complaints rarely change the diagnosis or lead to treatments that improve outcomes. The emotional impact is real. Seeing the word lesion or atrophy on a report can produce anxiety and a sense of lost independence even when clinical testing shows preserved function. George, age 74, went for a brain MRI after family members noticed he was misplacing keys more often. The MRI report noted age-related changes, which alarmed his family and prompted consultations with specialists. A full cognitive screen performed by his primary care team and a geriatric assessment showed his memory changes were mild and consistent with normal aging. Together, George and his clinician prioritized sleep hygiene, social engagement, memory strategies, blood pressure control, and aerobic exercise. Over the next year, his daily functions stabilized, and he avoided a cascade of invasive tests. A safer first step for mild memory concerns is structured cognitive screening and a careful assessment of reversible contributors. Medication effects, mood disorders, hearing or vision problems, sleep apnea, thyroid function, B12 deficiency, and vascular risk factors. If clinical signs point to a focal neurological problem, sudden decline, or red flags like stroke symptoms, targeted imaging is appropriate. But before a brain MRI for mild complaints, ask, what happens next? If the scan shows non-specific changes, how will that alter care, and could it lead to interventions with risks or no benefit? 3. Cardiac stress tests in people without classic symptoms, false alarms, and invasive cascades. Cardiac stress testing is designed to unmask coronary artery disease by showing how the heart performs under stress. It's a cornerstone when people have chest pain, exertional symptoms, or other signs suggesting ischemia. But among older adults who don't have typical symptoms, stress tests have a high rate of false positives. Testing a population with low pretest probability can produce misleading results that prompt angiography, stent placement, or other procedures that carry risk but may not improve survival or functional outcomes. JAMA Cardiology and other cardiology reviews have examined how overuse of stress testing in low-risk patients leads to more downstream invasive procedures with limited evidence of benefit in asymptomatic or minimally symptomatic older adults. There are real procedural risks to consider: contrast-induced kidney injury, bleeding complications, vascular access problems, and the psychological and practical toll of hospitalization and recovery. Raymond was 75 and feeling generally well, though he mentioned occasional fatigue. His clinician ordered a routine exercise stress test just to be safe. The results suggested ischemia, and he was referred for cardiac catheterization. That procedure led to a stent placement and exposure to contrast dye. Within days, he developed declining kidney function attributed to the contrast, requiring additional hospital care and therapies. Raymond's mobility declined during recovery, affecting his independence for months. In the end, the stent did not clearly change his long-term prognosis. When should a cardiac stress test be considered? Reserve stress testing for patients with symptoms consistent with coronary disease, significant ECG changes, or new concerning limitations when confirmed by clinical judgment. For older adults without typical symptoms, start with a thorough history, resting ECG, and assessment of functional capacity. When imaging is needed, discuss the probability of false positives and the likelihood that a positive test would lead to invasive action. Consider a coronary artery calcium score or targeted evaluation when appropriate. And again, ask, what happens next? If the stress test is positive, what are the likely steps? Angiography, stenting, or medical therapy? And what are the risks of those steps for someone your age and health status? 2. Colonoscopy screening after age 70 to 75, balancing life expectancy and procedure risk. Screening colonoscopy has been hugely successful in preventing colorectal cancer in many people, but after a certain age, the balance shifts. Colonoscopy requires bowel preparation and often sedation. It carries a small but real risk of complications that rise with age, including bleeding and bowel perforation, and the procedural burden is not trivial for frail older adults. Guidelines from geriatric and preventive care organizations advise individualized decision-making about continuing routine colonoscopy beyond age 70 to 75, depending on life expectancy, prior colonoscopy history, overall health, and patient preferences. Studies and reviews have shown that the benefit of screening in preventing death from colorectal cancer decreases with limited life expectancy because the time to benefit from screening can be several years. Dana's experience highlights the stakes. At 73, she underwent a screening colonoscopy while feeling well. During the procedure, a small polyp was removed and she was discharged. A day later, she developed severe abdominal pain and was found to have a perforation, an uncommon but serious complication. Dana required surgery and a prolonged hospital stay, with a slow recovery that impacted her independence for many months. Her clinicians later discussed that, given her overall health and the likelihood that a screening result would not change long-term outcomes, less invasive options might have been reasonable. For many older adults, stool-based testing, such as the fecal immunochemical test, FIT, is a reasonable alternative that avoids the immediate risks of sedation and perforation and can be repeated regularly. If a prior colonoscopy within recommended intervals was normal, continuing routine invasive screening may offer limited benefit. The choice should reflect life expectancy, comorbidities, and what you value most. And before scheduling a colonoscopy, ask what happens next. If a polyp is found, what interventions will be recommended, and what are the risks of those treatments for someone your age? 1. Annual full-body CT scans, radiation, incidentalomas, and dangerous downstream procedures. Full-body CT scans marketed as screening are tempting, a single image that promises to catch something early. But routine whole-body CT in asymptomatic adults is not supported by evidence and often causes harm. CT scans expose people to ionizing radiation, and while a single scan's risk is small, regular whole-body imaging adds up. A recent modeling study estimated that population-level CT exposure may contribute to a measurable number of cancers. Some estimates have suggested figures in the low single-digit percentage range of cancers could be attributable to medical radiation, depending on the population and assumptions. Additionally, CTs frequently detect incidental findings, incidentalomas, that are benign but prompt biopsies, surgeries, or procedures that carry significant risks. The American College of Radiology and other professional bodies advise against routine full-body CT screening in asymptomatic individuals. JAMA and other journals have discussed how such screening tends to lead to more harm than benefit, particularly in older adults whose life expectancy and comorbidities change the calculus. Marcus, age 80, decided to get an annual full-body CT because it felt proactive. The scan revealed a small lung nodule. Worried about cancer, his clinicians recommended a biopsy to be sure. The biopsy resulted in a pneumothorax, a collapsed lung that required hospitalization and a chest tube. Marcus spent weeks recovering, lost weight and strength, and needed extra home support while he healed. The nodule later proved benign. His well-intended screening created suffering without clear gain. For asymptomatic seniors, routine full-body CT is generally not advisable. Targeted imaging for specific symptoms or new clinical findings is a safer approach. If imaging is considered, ask what follow-up would be required for a suspicious incidental finding and whether that follow-up could be more dangerous than the thing being looked for. Always ask what happens next. If a scan finds an indeterminate lesion, what diagnostic pathway will follow and what are the risks at each step? A decision framework to use before any test. Pause and ask 3 things. Before consenting to any diagnostic test, particularly if you're over 70, take a moment with your clinician and ask, what is the test looking for? How likely is it to find something that matters to my health in the next few years? And, importantly, say this out loud, what happens next? That last question forces a conversation about the downstream pathway. If the test is positive, will it lead to more imaging, biopsies, medications, hospital stays, procedures that could affect your independence? Will the interventions change your expected quality or length of life? What are the possible harms of those interventions? This framework shifts the conversation from "should we test" to "will testing likely help me maintain what I value?" It encourages shared decision-making that incorporates life expectancy, comorbidities, functional status, and personal priorities. For example, if a test is likely to find a slow-growing condition that would not affect your life expectancy or daily ability, avoiding the test might spare you unnecessary risk. Conversely, if a test has a reasonable chance of detecting a treatable problem that meaningfully affects your survival or function, it may be appropriate. Every decision should consider alternatives. For many of these tests, safer options exist. Non-invasive screening like FIT for colorectal cancer, structured cognitive testing and lifestyle interventions for memory complaints, resting ECG and careful clinical assessment before cardiac stress tests, strength and balance programs instead of immediate medication for borderline bone density findings, and targeted imaging for specific symptoms rather than whole-body scans. These alternatives are not guaranteed to prevent every bad outcome, but they often reduce the immediate risks associated with invasive or high-radiation tests. Practical steps to bring to your next appointment. When you schedule or are offered a test, bring a short list of questions. First, ask about the test's purpose and what finding it could change in your care. Second, ask how likely the test is to find something relevant given your health and age. Third, ask what happens next and request specifics, potential follow-up tests, procedures, and their risks. Fourth, talk about your goals. Are you prioritizing longevity, avoiding hospital stays, preserving independence, or all of the above? Finally, consider asking whether a less invasive option is reasonable to start. These conversations can feel uncomfortable, but most clinicians welcome them. Framing the discussion around what matters to you, preserving independence, minimizing time in the hospital, staying active, helps clinicians tailor recommendations. Shared decision-making is a partnership, and it's appropriate for you to request time to weigh the options, ask for a second opinion, or seek a geriatric consult if your situation is complex. Prevention matters, but so does how we prevent. Across these 5 items, the recurring theme is prevention by sensible means. Lifestyle choices remain among the most powerful tools for preserving health as we age. Regular moderate aerobic activity, resistance and balance training, adequate sleep, social engagement, proper hydration, a diet rich in vegetables, lean protein, calcium and vitamin D supporting foods when appropriate, and careful medication review to remove unnecessary drugs all reduce risk for many of the problems these tests aim to catch. Managing blood pressure, glucose, and cholesterol as recommended by your clinician, quitting smoking, and getting vaccinations are also important. But lifestyle changes aren't a panacea. They complement individualized medical care. The point is not to avoid clinicians or tests, but to choose tests when the expected benefits outweigh the harms given your personal health, goals, and time horizon. A quick recap of the 5 tests to be cautious about after 70. DEXA bone density scans that can lead to medications with side effects when the short-term benefit is small. Brain MRIs for mild memory issues that often show age-related changes and trigger anxiety. Cardiac stress tests in asymptomatic older adults that can produce false positives and lead to risky interventions. Routine colonoscopy screening past the usual age thresholds where procedural risks rise and benefits decline. And full-body CT scans that expose you to radiation and incidental findings that often lead to invasive follow-up with little proven mortality benefit. One last reminder, this video is informational and not a substitute for medical advice. Talk with your primary care clinician, cardiologist, or geriatrician about how any of these points apply to your specific situation. If this helped you, like and subscribe. And please share your story in the comments so others can learn from your experience. We read them and learn together.